Part 1. The pandemic of allergic, autoimmune and neuropsychiatric diseases and multimorbidities. This is the time course of allergic diseases, starting from 1819 with the first demonstration of John Bostock and the first book of Charles Blakely on hay fever and hay asthma, in which he collected the first 28 cases, and it took him 3 years to collect these cases. And at that time, lawn making, house heating, increased grass pollen exposure were mentioned to play a role in the development of allergic diseases. But their prevalence was very low, and the diseases were mainly existing in big cities. And here we have a big change starting from 1960s, because we realized that hospitalizations increased in UK, and this was followed by Australia, UK, New Zealand, Canada, and USA. And these were patients coming from inner cities, and the hospitalizations increased mainly in the capital cities of these countries. And we realized that there was rising incidence in the soldiers, also coming from the cities, not from the countryside. We come to 1989. This is the reunification of Germany. And here, in the beginning, East Germany had the prevalence of asthma and atopic dermatitis around 1 to 1.5%, and West Germany had around 10%. Within 10 years, in the year 2000, East Germany levels reached to West Germany levels, with the children becoming sick and developing asthma, atopic dermatitis, and allergic rhinitis. Here we see the first curve, and this is increased prevalence of allergic diseases. But we realize later that autoimmune diseases are also increasing at the same time, and metabolic conditions. And there's the obesity pandemic, and there's type 2 diabetes, rheumatoid arthritis, multiple sclerosis. And this was happening in the industrialized countries. Then we have a second curve related to food allergy, peanut butter sensitization and anaphylaxis, and eosinophilic esophagitis. And this second curve starts around 2000s. And here we see WHO numbers. In 1960s, there was 30 million patients with chronic non-communicable diseases, which increased to around 2 billion patients with 100 times increase. At the same time, world population increased by 2 times. That means there was a net 50 times increase in the prevalence of these diseases. Then we have another curve. This is the curve of big developing countries, mainly China. For example, asthma was 0.8% in 2000, and nowadays we are talking about 10% asthma prevalence in China. So the epithelial barrier theory includes the barrier damage, microbial dysbiosis, and immune system activation. And our work in this area started with the first studies with Axel Trautmann on skin and lung barrier in eczema and asthma. In around 2006, we published in Current Opinion Immunology first highlights of the epithelial barriers and understanding of the epithelial barriers to keep away the factors, to wash the factors if there's too much inflammation, and to suppress around the epithelial barriers. Then we identified immunological effects that open or close the epithelial barriers, and then we started to focus on the environmental change, exposome change, and toxic substances. So when we are talking about gut-skin axis, skin-lung axis, gut-brain axis, gut-lung axis, lung-brain axis, they are all happening in the epithelial barrier theory, and one organ is inflamed, and the inflammation is carried to other organs and makes them sick. And the old theories like hygiene hypothesis, danger hypothesis, old friends, ignorance, these hypotheses are all in the epithelial barrier theory. They are covered, and epithelial barrier theory is an umbrella theory that covers all the possibilities related to immune system activation, microbial dysbiosis, and epithelial barrier damage. We tried to identify the diseases related to the criteria, and our first criteria was increased prevalence of the diseases after 1960s or after 2000s, which is not affected with the changing method of diagnosis. As an example, when you look at eosinophilic esophagitis, when we were in internal medicine, we were making endoscopies, and then hematoxin and eosin staining was sufficient. Or when we were doing ultrasound, when you touch the probe to the abdomen, you can easily see that there is fatty liver within a few seconds, and it's still the same method. of diagnosis. So the diagnostic method stays the same here, but the prevalence shows a very significant increase. The second criteria is epithelial barrier defect and epithelitis with the activation of inflammasome, release of alarmins, interleukin 25, interleukin 33, TSLP, and multiple chemokines. And the third criteria is microbial dysbiosis is always associated with the immune system activation or epithelial barrier damage or epithelial cell activation. And this is characterized with the loss of commensal bacteria and colonization of opportunistic pathogens. For example, Staph aureus colonization in atopic dermatitis, in chronic rhinosinusitis, Borexella, Haemophilus pneumococcus colonization in asthma. And then the fourth criteria is the pandemic of multimorbidities, different and practically irrelevant diseases that fulfill these criteria appear in multimorbidities. That means in our old times when we were assistants, we were seeing these diseases as single entities, but currently we are seeing them together. So an asthma patient develops colitis and also has chronic depression at the same time, or an allergic rhinitis patient develops atopic dermatitis, but at the same time has a chronic eye disease or chronic heart disease. And the fifth criteria is circulating inflammation. That means we are seeing visibly by our new methods, by doing deep omics analysis of the circulation, looking at the cells there and looking at the inflammation that carries the inflammation from one organ to other. So with this way, we identified more than 70 diseases. And this is a further reading. It's a very detailed article with the involvement of worldwide experts of many organ disciplines. And here we can see that we have the diseases related to skin, which fulfill these criteria: atopic dermatitis, alopecia areata, allergic contact dermatitis, irritant contact dermatitis, psoriasis. And in the airway group, we have asthma, allergic rhinitis, chronic rhinosinusitis, COPD, and many others. In the digestive tract diseases, we have eosinophilic esophagitis, periodontitis, food allergy, inflammatory bowel, celiac, and many other diseases. The neuropsychiatric group has Alzheimer's, Parkinson's, autism spectrum disorders, stress-related psychiatric disorders, chronic depression, ischemic stroke, migraine, multiple sclerosis, amyotrophic lateral sclerosis. The autoinflammatory and metabolic conditions is a big group with rheumatoid arthritis, osteoarthritis, diabetes, obesity, metabolic dysfunction associated with cirrhotic liver, that means fatty liver. And we have here autoimmune hepatitis, thyroid diseases, systemic lupus. And we have ocular diseases with increased prevalence, age-related macular degeneration and glaucoma, dry eye, uveitis, and also allergic conjunctivitis, and other diseases, and end-stage renal diseases, heart failure, myocarditis, osteoporosis, anemia, hemolytic uremic syndrome, sepsis, severe COVID, cardiovascular diseases, polycystic ovary. They are all involved with these criteria. Another important paper which I'll mention here is the One Health concept, because pets and domestic animals are also showing increased diseases, and that's an important thing because of their very high exposure to mainly pet food, which is packaged food containing many emulsifiers and additives, and also they are exposed to air pollution like humans, or they are exposed to microplastic like humans. So this has made a big financial burden, of course, increasing the chronic non-communicable diseases to around 2 billion patients. And it affects the GDP of many countries, and health expenses in the world average increased to around 10%. And in the US, in 1990, only one single disease, asthma, was costing $10 billion. Currently, it is around $150 billion. And in the next years, $2 trillion is needed for asthma in the United States and Europe. So one single disease will cost a huge amount of money. Yes, the non-communicable diseases cost more than $10 trillion per year in the world, and about 17.6% of the GDP is used for health in the US in 2024.